All right. Hi, everyone, and welcome. I'm so glad you could join us for today's program, Multiple Myeloma Creating Diverse Treatment Options Through Clinical Trials. My name is Stephanie Trong, and as the founder of The Patient Story, and more importantly, someone who's dealt with her own blood cancer diagnosis, I've spent a lot of time talking with other patients, care partners, and doctors about how we can go about making the best treatment decisions, including figuring out when do clinical trials enter the conversation, right? Especially in the space of myeloma, where there's just so much development that has happened. I know firsthand how confusing and overwhelming it can be just trying to navigate those options. And that's why we're here today to try and give you the information and then, therefore, hopefully, the confidence that you need to have those important conversations with your own care team. Before we dive in, I want to give a big shout out to our friends at the Leukemia and Lymphoma Society, or the LLS. As you probably know, they offer so many fantastic resources, including the free one-to-one support in navigating clinical trials. That's with their Clinical Trial Support Center. I've had the pleasure of speaking with many of their nurses who are there for you on the other end of that line, and they are fantastic. It's clear that not only do they know a lot about clinical trials and how to navigate them, but they just really care about these relationships and the people they connect with. So they've got the Clinical Trial Support Center, and they also have got other resources, and we'll make sure to put the links in the program here as well as in our follow-up emails. So for today's discussion, we did team up with the LLS, which supported and sponsored this program, and also with one of its community outreach managers to bring you a special conversation. So you're going to hear from Bryon Daily in a bit, who was diagnosed himself with multiple myeloma. That was in 2018. He had a basketball injury that then led to the diagnosis. And after years of navigating his own myeloma treatment, Bryon's been dedicating his time to helping other people find their way after diagnosis. So he's going to sit down with Dr. Ajai Chari, one of the leading experts in multiple myeloma. Dr. Chari is from University of California, San Francisco, or UCSF. And that's actually where I got my own care, but in lymphoma. So they're going to talk about the latest in treatments, research happening through clinical trials, and why at least knowing your clinical trial options matters so much for us as patients and care partners, that it may not be that last resort, that it really has the ability to bring tomorrow's treatment to you today. And it's really just about figuring out, is this the right trial for me? So a quick reminder, while we hope you find this discussion to be helpful, it is not a substitute for medical advice. And so please talk to your own healthcare team about what's right for you. And finally, I know you want to hear from panelists. We really want to hear from you. We know it takes a lot to show up, and your feedback helps us to make these conversations better. And after this discussion, a quick survey is going to pop up. It should just take a few minutes to fill out. So please let us know what you think and what you'd like to see next time. All right, with all that said, let's get started. Bryon, over to you.
Welcome, everyone, to our discussion on treatment options for patients with multiple myeloma and the importance of clinical trials in battling this disease. My name is Bryon Daily. I am currently the National Community Outreach Manager for the Leukemia Lymphoma Society's Myeloma Link Initiative. I am also a 6-year survivor of multiple myeloma. Having been diagnosed back in 2018, I have no history in my family that I'm aware of cancer. So needless to say, it was a surprise when I was diagnosed. But that diagnosis actually came as a result of my primary care physician being very diligent in following certain trends during my labs. I had escalating protein over the course of several months. And it wasn't until about the 6th month when I was at the gym, just playing basketball routinely, caught the ball wrong with my finger, went home thinking it was a simple sprain. 2 weeks later, it didn't heal. It was just as if it happened the day before. And so I went to my doctor. We did an image, and it turned out to be a fracture. The fracture paired with the escalating levels of protein was a red flag for my primary care physician. And fortunately, he was able to refer me to several specialists until maybe about a month later, we ultimately went to see an oncologist who ordered a biopsy, and it turned out to be myeloma. I went through several months of chemotherapy and ultimately had a bone marrow transplant. It was successful. I was able to donate plasma back to myself, which is called an autologous transplant. And after several months of being out of the public domain, I began to recover. Today, I'm joined by Dr. Ajai Chari. Dr. Chari is a hematologist oncologist at the University of California, San Francisco. He is the director of multiple myeloma program and professor of clinical medicine. His research interests include the development of novel chemotherapy regimens, including phase 1 and 2 studies. Dr. Chari, our audience today is patients and their caregivers and partners. What is the number one takeaway you hope that they walk away with before we dive into details?
Well, thank you, Bryon, for having me today. It's a pleasure to be with you, and thanks for sharing your story. I guess if I had to say the number one thing patients are looking for is, I think, hope, right? I think they want to know that they're going to be able to live as long as they want to live, and not just long, but with good quality of life.
So, doctor, what is multiple myeloma and how do we treat it?
So myeloma is a cancer of the plasma cells. So the hallmark of a cancer, any cancer, is that one cell in the body grows out of control. And when it's myeloma, it's a plasma cell. They live in the marrow, so we call it a bone marrow disorder, but the manifestations can be in the blood and outside the bone marrow. So the symptoms of myeloma, when those plasma cells grow too much, is summarized often by CRAB, high calcium, for C, renal failure, kidney dysfunction, A for anemia, and B for bone disease. So patients can present, if they're hypercalcemic, they can present with confusion, bone pain. Kidney failure can often be subtle. They may see foam in the urine. If advanced kidney failure, they may see fluid retention, nausea. Anemia often presents with fatigue, and that's probably one of the more common symptoms. And because it's a slow-growing condition, usually, it's not something that pops up right away, but patients may notice gradually they're not able to walk as briskly or go up hills or stairs as readily. And bone, everybody can have bone pain, especially as we get older, but it's persistent, severe bone pain, not just comes and goes, or fractures. So those are the primary symptoms of myeloma.
So, Dr. Chari, we covered myeloma. How do we treat it?
So at a high level, cancers can be treated theoretically by chemo, radiation, or surgery. And there's really not a role for surgery other than to fix a fracture in myeloma because it's a bone marrow cancer. And radiation can be used for spot welding of pain at a particular site or maybe spinal cord. But the mainstay of therapy is systemic or whole body therapies. And sometimes people get concerned about the term chemotherapy, immunotherapy. I just would say any drug that's used to kill cancer theoretically could be called chemotherapy because it's killing cancer. And a good example of that is steroids, right? Everybody's least favorite drug. Dexamethasone technically kills myeloma. And so the classes of drugs in myeloma, which we can use any of these classes in a newly diagnosed patient, are steroids, conventional chemotherapy like cyclophosphamide, melphalan are often common, immunomodulatory drugs like Revlimid and Pomalyst, proteasome inhibitors like Velcade and Kyprolis, immunologic drugs like naked monoclonal antibodies, daratumumab, isatuximab, CAR-Ts and bispecifics, and finally, there's an XPO inhibitor named selinexor. So those are the 6 classes of drugs, and we can mix and match these based on efficacy and safety data, how well they work and combine. So for a newly diagnosed patient, I think the field has moved to, at a minimum, 3 drugs. Everybody gets steroids, at least at the beginning. Most people get Revlimid, which is an oral drug, and most people also are getting CD38 antibodies, such as daratumumab or isatuximab. There's now a movement historically for younger patients, but now even older patients, to also get that 4th drug, proteasome inhibitor, either Velcade or Kyprolis. I think the challenge there is that Dara, Revlimid, and Dex, which is called DRD or Maya, is projected to give a 5-year remission for the typical older patient, even without a transplant. And so to me, it's not clear that every patient needs an extra 4th drug, because with the 4th drug can come additional side effects. But if it's a fit older patient, certainly 4 drugs can be done. And I think the other question is, how long do you need to continue? There's these movements to down with Dex, right? Like get the myeloma under control, but then drop it off. And then similarly, drop off the proteasome inhibitor. So that's the initial therapy, 3 or 4 drugs. And then for younger patients, there's the question of whether or not to do the transplant. I think it's not wrong to do the transplant, particularly for high risk. The value add is even higher. For the typical patient, transplant adds about 16 months of remission. For high risk, it can be even up to 3 years. Now, people are not, some people really have aversion to transplant, and I think are more interested in CAR T, but we need those data sets to read out that CAR T is better than transplant. And then whether or not you do transplant, then you go to maintenance therapy. Typically, of those 3 to 4 drugs, Revlimid is the easiest drug to maintain because it's a pill. Some people also get Dara, and very rarely we also do the other drugs. So that's the initial therapy, and we hope these remissions last a long time. And some of the quadruplets are now projected to last, believe it or not, 90 or 100 months, so 8 to 9 years, so which is amazing. But unfortunately, many patients will relapse. So when a patient relapses, now the principles are you could go back to any of those drugs on that 6 classes that I mentioned, except you can't go to drugs that the patient's no longer responding to. So for example, if somebody was on Revlimid maintenance, you wouldn't use that. If somebody was on Revlimid and Dara, you wouldn't use those. And so then I think here there's a lot of options, and it's impossible to go through that in a short time. But at a high level, the more high risk the patient is, meaning the earlier the relapse, the more aggressive the relapse, the more you might want to consider CAR T because it's now approved for 1 to 3 lines of therapy. The more slow and well-behaved a myeloma is, but still comes back, you may be able to get away, for example, with a CD38 carfilzomib dex, like Dara carf-dex or ESA carf-dex. You could also use the other drugs that we mentioned, like pomalidomide. So at a high level, that would be the first relapse. So there's now data to even potentially, not yet approved, but belantamab, an antibody drug conjugate, could also be used in this space. And then lastly, if you've had, let's say, more than 1 relapse, so you've had initial therapy, first-line therapy, you're now in second beyond, it's the same principles. You can't go use to drugs that the patient's no longer responding to. And of course, you wouldn't use drugs that patients didn't tolerate in the past. But beyond that, you could come up with any other combination. So, for example, you could do carfilzomib, pomalidomide, and dex if you haven't had those drugs before. So you kind of use all the drugs that you can. Currently, bispecifics, which are also exciting, require 4 or more lines of therapy. So that's kind of how the sequencing works. And I think it's very important that CAR Ts, if you're going to consider it, be done before bispecifics and antibody drug conjugates, because that will adversely affect CAR T outcomes. So that's a high-level overview of how we approach myeloma therapy.
What role do demographics like age, gender, and race play in treatment?
We would love to personalize myeloma. And I think probably our closest example is translocation 1114, which was a drug that's targetable by venetoclax, but it was very complicated. And I think part of the reason is even though patients did better with that drug, the studies were not always clear. And I think it has to do with how complex myeloma is. It's not just the genetic. There's also a lot of these patient factors. And so these factors are important. I think probably with age, one of the unmet needs in myeloma is frail elderly, people who are, say, 70 plus with a lot of medical problems. We have to do better for them because it's great to have all of these amazing regimens, but if you can't give it safely, that's a problem. But younger patients typically do better. Gender, I think we've seen pretty balanced outcomes. Probably one thing is that CAR Ts with the rare Parkinsonism seem to be seen more in men than women, but that's also because that's where the demographics of Parkinson's are. More men get them than women. And then race, probably the biggest thing is disparities in outcomes, right? That not everybody's getting access to therapy. And for example, when you look at the Veterans Hospital where everybody has access to therapy, you don't see the differences in race-based outcomes, right? It's when you take away those equal access to therapies that you start to see differences. And in fact, there's some studies suggesting that African Americans may actually have better disease biology. So they may actually even have better outcomes with the same therapies if everybody's getting access equally. And I would add to that, not just a race, but anybody underserved, which includes economically disadvantaged and also people in rural communities, right? Where we're such a large country. And if you live in a rural part of the country, you may not have access to some of the novel, exciting therapies. So we have a lot of work to do into transposing all these amazing outcomes and really exciting drugs to all patients in the US with myeloma, and honestly, globally too.
So, doctor, when I was diagnosed, I had a sit-down visit with my oncologist to discuss next steps. And we talked about clinical trials, of course. That's not always the case. However, it was presented to me. I decided at the time that I didn't know enough to make a decision on the spot, and asked, what is the standard line of treatment? I'd prefer to follow that and then see what happens. How do you decide what treatment options are best for a patient?
Well, the first thing I would say is myeloma is not one of the most common tumors, right? So like the most common cancers that are seen are usually breast, colon, prostate, and lung. I bring that up because if you're a patient that's diagnosed in the community, chances are your oncologist is very experienced with those cancers, but maybe not as much with myeloma. And studies show that outcomes for patients who are affiliated in some way with an academic center do better. So even if you get your treatment close to home, which by all means, I always tell my patients, you don't get points for suffering. You don't need to drive hours to come see me, bridges, tolls, parking, to get the same treatment you're going to get close to home. However, you should have a connection with an academic doctor who knows and keeps up with the latest data, because I can tell you that myeloma publications are like reading drinking from a fire hydrant. Every year there's multiple high impact publications. And as a community oncologist who's treating all those other cancers, how can you possibly expect one person to be an expert at everything? So I think if you're a patient, you want the expert opinion, but you want the convenience of getting it close to home. And so at a minimum, get that academic opinion, hear about the options that are being proposed, which may or may not include clinical trials, and then make a decision. And then I think we're going to talk more about clinical trials, but I guess I would just say at a high level, remember that today's clinical trial is tomorrow's standard of care. Every treatment that you're getting today was because people like you did studies before you. And we found that these newer therapies often displace the older therapies. So I think it's really important to get your options and also recognize that some patients may not be eligible, right? Because if you have kidney failure or your counts are too low, you may not be eligible for studies. But it never hurts to have the options.
Yeah, so a lot of your research has been focused on CAR T-cell therapy. Can you explain how it works and some of the challenges with T-cell therapies?
Yeah, in some ways, people ask, why did I get myeloma? And the short answer is we don't know, but the fact that most people get it in their 60s and 70s suggests that perhaps the immune system gets lazy as we get older. And maybe we all can have a little bit of cancer when we're younger, but our immune system gets rid of it. And as the immune system gets lazy, we can lose that ability. So one way to deal with that is you can take somebody's T cells out, genetically modify them, and put them back in the patient. Essentially, these supercharged T cells can then kill the myeloma. And, initially, I have to say we were not too excited about these because we're taking, as with all clinical trials with new therapies, we typically test them in people who have exhausted all the available options, right? Because that's the only way to do it. If you don't know the side effects of something, you first start in patients who have very limited other options. And so when you take these patients who've been treated with many, many chemotherapy regimens and are older, you don't necessarily think those are going to work. But guess what? These CAR Ts are working like gangbusters. So when we put these supercharged T cells into patients, we're getting responses of 80 to 90% lasting 1 to 3 years in patients where you would historically expect at best a new exciting therapy to give a 20 to 30% response rate lasting for 3 to 4 months. So it's a paradigm shifting time, and CAR Ts have taken literally patients who are almost hospice bound and now put them in stringent complete remission off therapy, enjoying their life.
Absolutely. Another area of research for you is bispecific antibodies. What advantages do bispecific antibodies offer over CAR T-cell therapies?
So the CAR Ts, as I alluded to, have to be very personalized. You have to collect your T cells, genetically modify them, and put them back. So it's personalized therapy. And There's the time, what's called vein-to-vein time, which is from the collection to the administration. That can be anywhere from 4 to 6 weeks. But I would add to that, there's a brain-to-vein time. It's from the day that most patients who are in the community are being evaluated by their doctor. Hey, you may be a candidate, being referred to an academic center where that's being done, getting insurance approval, getting the collection. So that's called brain-to-vein time. And the problem is some patients don't have that luxury of waiting. Whether it's 4 to 6 weeks or several months if you include the whole process, if your myeloma is taking off, you don't have that luxury of waiting. So you need an off-the-shelf product that's ready to go that doesn't have to go through all of that. And then and that's where bispecifics come in. And then the other thing with bispecifics is that because it's like all of our other myeloma medications, if there's a side effect, you can stop the drug and hold it and wait for it to get better. With a CAR T, you administer that CAR T once it's manufactured, you put it all in, and then you don't really have control. You can't take it back. So if somebody does have severe side effects, you just have to manage them. You can't pause or interrupt or reverse that. So in patients who have a lot of medical problems, you have a little bit more control as a medical team over the bispecifics than you do the CAR. So that's probably the two big differentiation, off the shelf and the ability to stop the therapy.
Can you elaborate for me, if you will, on the development and potential impact of trispecific antibodies in multiple myeloma patients?
Yeah, right now, CAR Ts and bispecifics have historically targeted one antigen or one protein. So they target that's a protein that's ideally overexpressed on myeloma and not other cells. And the reason you want to do that is if you're going to activate your T cells, whether it's with a CAR or bispecific, you don't want them to attack your heart or kidney or lungs or normal parts of your body. You really want those T cells to be like snipers and go after the cancer. And so we do that by picking these proteins that are overexpressed on myeloma, but not your normal body parts. And then the other part in bispecifics, of course, binds your T cell. So bispecifics, half binds the T cell, your immune cell, half binds your myeloma. And in CAR T, the T cells are supercharged to kill one protein. Trispecifics are saying, well, why do we have to stick with one protein? Why not have the sniper go after two different proteins to perhaps increase the specificity? Because even though we're trying to pick proteins that are overexpressed on myeloma, some of the other cells that express these will also be hit. So for example, many people know about BCMA, which stands for B-cell maturation antigen. When you target that protein, you kill myeloma, but you also kill some other immune cells, which can then increase the risk of infections. The other big protein that we target is called GPRC5D, which stands for G protein coupled receptor class 5 member D. Mouthful, but basically, again, a protein that's overexpressed on myeloma, but it can also be overexpressed on tissues that have a lot of keratin, so nails, skin. So you see some of those side effects, and it also causes oral side effects like weight loss and taste. So the trispecific is saying, what if we do both of those? Let's take the T cells and attack GPRC and BCMA at the same time. Will that then decrease some of these side effects like infections and skin, nail, oral side effects? And can you get even better responses, right? Because this is a nuclear kind of warfare. When we go after one protein, guess what? The myeloma cell says, you think you can get me? I'm just going to stop making that protein. And then it evades that target. So by doing two at the same time, it's harder for the myeloma cell to kind of bypass that. So those are some of the theoretical benefits, which is maybe less side effects and maybe more efficacy, better activity. But we'll have to see. Preliminary data will be presented this year at our national meeting called American Society of Clinical Oncology. And I think there's a lot of excitement about this approach. And perhaps also one of the differences that when you give bispecifics and CARs, when you give that first dose, sometimes you have massive T cell activation. We call that cytokine release syndrome. And that can often be fever, low blood pressure, often admitted. And one of the other questions is, by doing this dual targeting, will that maybe make that safety profile also better? So all data that we're really excited to hear about.
So a lot of these novel and innovative treatments that you mentioned have just emerged over the past few years at a rapid pace. Let's talk about clinical trials. There have been a few trials recently looking at different combination therapies, such as DREAM7 trial, the Majestic 5 trial, and Auriga trial. What are researchers hoping to understand about these treatment options?
So maybe if we start with the patient journey, most people are getting initial therapy, so some kind of combination, 3, now often 4 drugs. Then many people are getting transplant. I think you mentioned you had that. Then what happens after transplant? And so the Auriga study is saying if you've gone through initial chemotherapy and transplant and you still are not what I call the A+ of myeloma, which means not only have we eradicated all the myeloma in the blood and the urine, and the bone marrow, but even the minimal residual disease, which is picking up 1 in a million cells. If that's still positive, meaning you're not getting an A+, you might be an A or A-. Can we improve your outcomes to get you to an A+? And in Auriga, the way that was being done is everybody got either, you had to be MRD positive after transplant, and you could not have had CD38 antibody like Dara or isatuximab in your initial therapy. So if you got chemo, transplant, and you were MRD positive, half the patients got Revlimid or lenalidomide alone, and the other half had the addition of daratumumab as a shot. And what that study showed is that the A+ conversion was improved, so more patients got MRD negativity, and more importantly, that translated into doubling of the remission duration. So that's now a strategy that could be used, although it's a randomized phase 2, not a phase 3. A lot of excitement about trying to improve that outcome. Majestic-5 similarly takes patients who are post-transplant and asks, rather than just doing, most of us are doing Revlimid maintenance as a minimum, can you do better than that? And one of the ways they're trying to do that is with incorporating a BCMA bispecific known as teclistamab. And so that's why it's called Majestic-5, because the TEC in Majestic. And so the addition of BCMA bispecific to Revlimid in this study, now this is not a randomized study, it's a small study, only about 30 patients in 2 different arms, shows really dramatic responses where the MRD negativity, meaning achieving the A+, was markedly increased. Pretty much everybody got to MRD negativity in this study. And so I think we need larger numbers of patients. Now, of course, we haven't talked a lot about side effects, but these bispecifics can increase the risk of infections when you're targeting BCMA. So we're going to need larger data sets to understand how to put that getting an A+ into context with potentially the risk of infections and needing preventative drugs for infections and IVIG. But, it's hard to argue against an A+ for 100% of patients. And so I think that's where a lot of excitement is. And then the last study you asked about, which is DREAM-7, is you've gotten initial therapy and you've got your transplant or not, and then you had your maintenance or not, but now perhaps the myelomas come back. So we're now in relapsed myeloma. And then the question is, what can you do there? And historically, a lot of patients, because they're getting Revlimid maintenance after transplant, you can't use Revlimid anymore and you have to move on. And this study said, well, we could use daratumumab and bortezomib or Velcade and Dex, or can we do better than that? And so they took bortezomib and Dex or Velcade Dex, but it swapped out the Dara with a new BCMA antibody drug conjugate known as belantamab, mafodotin, or Bela for short. So basically, it's a 3-drug versus 3-drug combination. Everybody got Velcade Dex, and the question being asked is Bela versus Dara. And what that study showed was, surprisingly, the Bela beat the pants off Dara. And so this was a marked improvement in the remission duration. Now, this drug does come with eye side effects, so it can cause dryness of the eye, irritation, blurry vision. Most of that is reversible, and there can be sometimes holding and interruptions of the Bela. But this is a great option because this really, if you can beat the Dara, why not? The only limitation is very few people will be in this population. These are typically going to be older patients. I bring that up because most people who are younger and are relapsed myeloma, you're going to want to think about CAR T for that patient. And if you give drugs like Bela or BCMA bispecifics, you're going to impair the CAR T outcomes down the road, because we know from some clinical trials that if your CAR T, for example, Carvykti or cilta-cel gives a 3-year remission, if you give a bispecific, that goes to 5 months. And if you give an antibody drug conjugate, that goes to 9 months. So we really don't want to impair that amazing CAR T outcome. So but those who may not be CAR T eligible, either they don't want to do it or they're perhaps old and have a lot of medical problems, this Dream7 could be a really good, exciting option and could be done in the community. That's the other big difference. You don't need to go to an academic center to get belantamab. So those are the 3 studies that I think you asked about.
Yeah, thank you for that. Why should a patient consider a clinical trial?
The best way I can answer this is that when I was in New York, I was in New York for about 18 years. In the early part of this decade, probably CAR-Ts and bispecifics the studies started in maybe 2017, 2016. And I remember patients had exhausted all the therapies at that point. They'd had the big 5, right? Revlimid, Pomalyst, Velcade, Kyprolis, and Dara. So what do you do with somebody like that? And so we've literally had hospice conversations with some people. We're like, but let's try this study. And those patients are now in their most deep and durable remissions in their entire myeloma journey, despite having had all those drugs. And I think that's a clear example. If you've run out of options, then you should be looking for new strategies, right? And so I think many people would understand the need for clinical trials there. But I would say it's also important, even if you're newly diagnosed or maybe early relapse, to think about a clinical trial, because if we didn't, we would really, back when I was a fellow, our initial therapy was 2 drugs, Revlimid and Dex, right? And how would we know that we need to do 3 drugs and 4 drugs and transplant and maintenance and all of that? That's been incremental learning from every clinical trial, and that's how medicine progresses. So I think it's always good to think about how you can get the best care for yourself and how you can advance the science for everybody.
So the results of those clinical trials basically help to determine what's best for any given patient based on the data that comes out of that. There are a lot of myths about clinical trials, as you know. One of the concerns we address with Myeloma Link is the fear that people will be receiving a placebo and get no treatment, or the participants are guinea pigs. Think about the Tuskegee syphilis study or the Henrietta Lacks harvesting of her cells. What do you tell patients about these fears?
I think fear is understandable, especially when you're dealing with a diagnosis of cancer. I remember when I was a medical student, we had a class called, "Is it cancer and can I still have sex?" The 2 questions patients had but were afraid to ask. And what you learn is that 50% of that information in a first cancer visit goes in 1 year and out the other, because you're dealing not only with the diagnosis of the cancer and the intellectual questions, but the emotional part. So I think it's always good first to have a friend or family member to listen in on all of your conversations so that they can help catch some of the things you might have missed, or record it if your provider allows you. Then I think it's also important to understand that because of the Tuskegee and Henrietta Lacks and all of these other stories, there's a lot of protections built in. I, as an investigator, can't just say, you know what, I want to test this new drug. You have to write a protocol. You have to write a consent form, which is reviewed by independent doctors at one committee, then a second committee, and a third committee. The FDA has to oversee it. And if it's a company, they have to oversee it. So there's a lot of checks and balances within the institution, in the pharmaceutical company, and the FDA. So there's 3 different major stakeholders. And then you have to ask, what's the question being asked? It is unethical, for example, to take somebody with advanced myeloma who has active disease and assign them to a placebo. That would never pass all of those various committees that I told you about, because it's unethical. Where you might see a placebo is you're not sure if you need an extra drug, right? Like if 3 drugs is doing pretty darn well and you want to add a 4th drug, you might have to do that if the placebo, because there is a placebo effect, right? And when people take a drug, they're going to feel better and they think they're getting a better outcome. So if there is something like that, but I have to say, in my experience with myeloma, the number of placebo-based studies are very few and far between. And probably the only time you see that is in maintenance, where you don't know if you should be doing something preventatively or just waiting for the cancer to act up, or perhaps in smoldering myeloma, where you don't have a symptom and you're trying to prevent the cancer, you might think about doing something like that. But even those, the field is moving. So I think in cancer, this kind of concern that you're going to be a guinea pig there's an admitted lack of knowledge. Otherwise, if we knew the answer, we wouldn't be doing it. So there is an inherent unknown. But I think we try to put a lot of safeguards in to mitigate that.
Understood. Let's talk about managing treatment. What are some of the common side effects people experience from treatment, and What can be done to mitigate them?
This is a complicated question because it really is very drug and therapy specific. So if you had to say steroids, everybody's least favorite drug, irritability, sleep, heartburn, fluid retention. So you try to lower the dose and, if possible, stop it, and maybe take a sleep medication. Conventional chemotherapies often cause lowering of blood counts because they kill the myeloma. So we're talking about drugs like melphalan, which is part of transplant. And there's some interest for hair losses. There's some interest in cooling caps that might be, they're showing some activity that we've seen at our institution. For the IMiD drug classes like thalidomide, Revlimid, or lenalidomide and Pomalyst, they typically are increasing the risk of blood clots. So it's important to take an aspirin to prevent that. And if you're on certain other drugs or you have a history of clot or high risk, you might want to take something stronger. With the proteasome inhibitors like Velcade, Kyprolis, Ixazomib, there's a risk of shingles. So you want to take a shingles preventative pill. And then sometimes one of those drugs, bortezomib or Velcade, can cause neuropathy. And also the carfilzomib can cause heart issues. So you got to monitor the blood pressure. The immunotherapy drugs can increase the risk of infections. So you have to monitor that. And then the CAR-Ts and bispecifics, I think we've alluded to, can cause cytokine release syndrome, which has to be monitored and treated. And then the bispecifics, infections and oral toxicity, which you have to do supportive care like IVIG or modifying the dose.
Yeah, what point would those side effects lead to considering switching a patient from one treatment to another?
This is always a balance between efficacy and safety, right? What kind of myeloma is this? How well is it controlled, and how bad are the side effects? So if somebody has very favorable myeloma with very little disease, you're not really going to tolerate much side effect. If you have very difficult to control myeloma and very high risk, say myeloma with multiple genetic abnormalities, myeloma that comes out of the bone marrow, it's harder to control, and there might be more willingness to take side effects. But ultimately, you have to give it a shot. I would just say to this point, this is why oncology is a specialty, right? You could ask, why can't these drugs be given by your primary care? Well, you got to know this kind of risk-benefit balance and walk this tightrope. And that's why we have frequent visits and frequent myeloma labs, so that you can really, at each month, make this decision about, okay, am I happy with the myeloma control, and how bad are these side effects this patient's having? And is the patient willing to continue with some modifications of dose and schedule or medication to offset side effects?
And multiple myeloma is generally diagnosed in older patients. So what are some of the quality of life considerations you discuss with patients who are younger than 50?
So I would say, my youngest patient was probably diagnosed at under 18, and then the oldest is over 100. So it's a very heterogeneous disease, and it's hard to do one size fits all. And I think as we get older, there's a movement in all of medicine, and specifically in oncology, to not use a chronologic age and to really focus on how healthy is that person. And there's some 70-year-olds who are going to be way healthier than 50-year-olds who might have multiple other medical problems. So I think for older patients, just looking at their other medical issues. But for the really young patients, things that are more important are talking about fertility, maybe banking sperm, freezing eggs if that's possible, and embryos, understanding that may or may not be feasible depending on the pace of the disease. Trying to walk that tightrope between preventing the disease from coming back, but also allowing these patients to live their life and work and be productive. So I think ultimately it's just what we do in oncology, right? You got to personalize the therapy for each patient.
And what are the most promising developments in multiple myeloma treatment that you foresee in the next few years?
Probably the first is this kind of moving of therapies that are currently in advanced myeloma to earlier and earlier lines of therapy. CAR-Ts initially were, heavily treated patients. Now they're approved in 1 to 3 lines, and there's clinical trials that may lead to their approval in newly diagnosed patients and perhaps even smoldering myeloma. Similarly, bispecifics are making their way up, showing, as we said, like 100% response rates and MRD negativity in earlier lines of therapy. We also need new therapies for combinations like let's say somebody's had CAR-Ts and bispecifics. What do we do then? So there's some new targets, oral medications in particular, because I think when you beat up all the T cells with all these therapies, you need non-T cell dependent strategies. So there's some new targets that are promising, like bromodomain inhibitors, also trispecifics that are targeting different antigens. So, and then we talked about dual CARs, triple CARs, newer CARs that don't have the same safety issues, some data that maybe we don't see Parkinsonism. So kind of improving on the existing therapies, moving them earlier, and then whole new targets.
How do you envision the integration of novel immunotherapies into standard treatment protocols for multiple myeloma?
Well, thankfully, the health authorities, both across the Atlantic, FDA and Europe, have allowed MRD negativity. And the reason that's important is if even in older patients, so there's a study called MAIA, which was median age of 73, who got DARA, Revlimid, and Dex. So if you start at 73, those patients are going to get 5-year remission from that. So if you're going to try to improve on that, imagine how long we're going to have to wait before hundreds of patients are accrued and randomized, and when we're going to find out if they're better. So the MRD negativity is a huge advancement in earlier lines of therapy, because then MRD negativity should then translate into progression-free survival, which is how long the remission lasts. And ideally, that could or may not, but could lead to living longer. And I mention that because sometimes people are looking for that overall survival improvement. But as you get to newer diagnosis of myeloma or less heavily treated, the amount of drugs that we have to rescue myeloma can make it very difficult to show that the initial therapy is going to translate into living longer. So I think the MRD negativity is going to be a big one. And then honestly, we need these clinical trials like CAR T versus transplant, which I think is super exciting. I don't think anybody wants to go through transplant voluntarily. And if we can do new therapies that don't cause hair loss, nausea, vomiting, diarrhea, weight loss, and fatigue, by all means, we should get rid of it. But we need the studies to show not just that it's better, but remember, we also need to think about long-term side effects, right? Because myeloma patients are living longer. There's an increased risk of getting other cancers. So we need to follow patients long enough to know that not only is the initial benefit there, but there's no unexpected longer-term side effects.
Dr. Chari, as we wrap up, if there's one thing you want someone newly diagnosed with multiple myeloma to know about their treatment options, what would it be?
I would say this is my passion, is the personalization of therapy, right? There are no two patients alike. And you can read about a clinical trial, you can go to a patient support group, you can talk to a friend, but that doesn't mean that's the right treatment for you, right? And there's patient factors like your age, your kidney function, your heart history, diabetes, neuropathy. There's the disease like your ISS stage, your genetics. Do you have myeloma coming out of the bone marrow, EMD? And there's treatment considerations, right? What side effects are you willing to accept? Can you take time off of work? Do you have a caregiver? What therapies have you had? So when you put all that together, I see a lot of patients that come in the door and they're so anxious. They just want me to give an immediate answer as to what I would recommend. And I try to tell them, like, I need all of this information. I need to know what your medical history is. I need to know all about your cancer. I need to know what you want as a patient, and then I can give you an answer. But if you just asking for an answer, you're not getting the best care. And that includes the options for clinical trials. So I would just encourage everybody to speak to a myeloma consultant at an expert medical center and then make sure that all of these factors are being considered to personalize a therapy for you.
Dr. Ajai Chari, thank you so much for sharing your insights. We hope this discussion has provided you with valuable information. We encourage you to follow or continue following the latest advancements in the field and to discuss your options with the healthcare providers. And please check out the Leukemia Lymphoma's Myeloma Link initiative and support for both patients and caregivers.
Thank you so much, Bryon. Thank you so much to Dr. Chari for leading this incredible conversation. And we're so glad that you out there could also join us today in being part of this discussion about promising clinical trials in multiple myeloma, hoping that it leaves you not only with new information, but some fresh hope, and definitely a reminder that you are not alone as you're dealing with this. One thing that we really want to emphasize is that every patient and care partner deserves to understand all of their options, and clinical trials are not just for someone else. They're not a last resort. They can really open doors to the latest in treatments and care. And so it's just about having the conversation with your own team to just know your options, right? It may not be the right one for you, but at least you have that at your fingertips And don't be afraid to ask your own questions, do your own research, and talk openly with your team. So be curious, keep advocating for yourself. And if you again need any support, don't hesitate to reach out to the patient's story or to the Leukemia and Lymphoma Society. The LLS has not only the Clinical Trial Support Center that I talked about earlier, with that free one-to-one clinical trial navigation that happens even before the clinical trial. It's helping you figure out the questions beforehand, which one might be right for you. But also, they've got community, peer to peer support. And so, just really deep and rich with resources. So, thank you again for being here. Don't forget about that survey that's coming up. We really do factor in all that you say, and we value your feedback and want to make these programs and stories as helpful as possible. So, remember, your voice and story matter. I'm Stephanie Trong for the Patient Story. Hope to see you again at another conversation. Take good care.